So, welcome. My name is Paul. Met most of you last week. So what we're going to go through is top 20 things not to miss in the emergency department. Now, primarily these are X-ray, but there are some clinical things as well to consider. Okay, it helps if I'm actually on PowerPoint to try and bring it forward. So there's a brief overview with some key plain X-rays, mainly about significant and easily missed pathologies. Now, some of you may have already will spot a recurring theme with some of these, and that is deliberate. And there'll be some main things of how not to miss them. And the main one is think about it. It will not replace detailed teaching on each of these individual presentations. So just because I've spoken to you for a couple of minutes about something does not make you an expert on it. It just makes you aware to think about it. It will not cover every encountered pathology and always interpret with the clinical picture. Okay? So if you think something's wrong, and the X-ray or CT doesn't say it, something does not say it's not. All right. So, first one up, the Friday night special. Guys, been out, drinking, chatted up the wrong person's girlfriend. Unfortunately, it was a bare knuckle fight to his girlfriend that he chatted up, and he's been met with a right hook. And he's got swelling to the left side of his face and pain. He's a bit drunk, but otherwise no concerns over any brain injury. So what sort of things are we thinking about here and worried about?
Fractures.
Fractures, precisely. What sort of fractures are we thinking of? Orbital fractures, yeah. So if you think about that mechanism, it's a blow to the lateral aspects of the orbit. So obviously you need to think about the bony structures, the eye, and the brain itself. It's not just the brain, CT fine, home. So if you look at this X-ray, as the arrows pop up, you'll see that there's a crack on that lateral border of the orbit, isn't there? But also, the zygoma is a tripod. It's also gone over the cheekbone component. And believe it or not, I can't actually see it even on the screen, let alone on the projection, has also gone further around in the arch. So just because you can see that fracture doesn't necessarily mean there isn't another fracture on there. Remember, the tripod can go in all three legs. And we've shown also, you've got the lateral view there. If you look at the, sorry, not the lateral view, the shoot-up view. And if you look at the shoot-up, I struggle to see any fractures on that. Possibly you can argue you've got one going through there. But realistically, there's no fracture definitely on that, which is the importance of getting those two views. So if you only got this view, you'd miss that one. Definitely miss that one because it's just not visible. Okay? Now, facial fractures are defined or described by Lefort classification. And Lefort was a slightly eccentric French doctor who decided that the best way to work out how things broke was to drop cannonballs onto skulls. And he defined 3 different types of fracture. So let me just try and admit. So we've got the Lefort type 1, where it goes basically through the maxilla. So you break of the teeth. Lefort 2, which is both fingers across the nasal bone. And Lefort 3, which is basically straight through the base of the skull. How they pan in reality is not as simple as just hitting a face with a cannonball, but you'll often end up with a mixture of partway going through the nasal bone and then going up through the orbit. We've gone through some facial fractures and the sort of things that, so at least you're aware of what the definition is. So, another Friday night special. This guy's finally got back to Canary Wharf. He's a 40-year-old, works in the finance industry. They've been well behaved for a long time, but they've got their bonus. And what do the city boys do when they get their bonus? They spend it. And this guy decided to spend it on one of Colombia's great exports, cocaine. And he's come in, he's got some heartburn. It feels this one's going up into his chest, up into his neck. But because he's 40, he's actually got an ECG, because we ECG everybody. So what can we see on here? What are we wanting to look for? We're looking for ST changes, aren't we? Because we're concerned his post-binge heartburn is it an MI induced by his cocaine? Yeah. So, if you look on V2 and V1, yeah, you can see there's some S2 depression. You can argue there's some elevation in V6, but also, what are these in V4 and V5? And the QRS complex is going negative before the upstroke of the R wave, isn't it? So it's got a Q wave in anterior leads as well. What are we thinking might have happened? Posterior myocardial infarction, precisely. And if we were to then look at doing posterior leads, we may well then end up seeing the ST elevation. But if you weren't thinking about it, you might ignore that depression in V2. Certainly if he doesn't admit to using cocaine. So if it was a 20-year-old who denies any cocaine use, you might not spot it. So think about it. So, moving on from the Saturday night and Friday night specials, this is more in line with normal for the Prue. Ethel's probably too old now. It used to be easy when Ethel and Doris were elderly. Now going to be like Joan or Jean. That's not an elderly name. Has been out shopping and she's tripped over the curb. She's got some neck pain. And CT, you don't need to CT her head. And somebody suggests, oh, we should just get an X-ray of her neck. Are we concerned about 70, 80-year-olds falling over and having neck pain? Yeah, because they can break their neck very easily. And she is not moving her head around at all. So, if we follow, there are three lines. So there's the anterior vertebral line. Notice any problems yet? Posterior vertebral body line. Oh, hang on. That should be nice and smooth there. And then you've got your spinous processes. Again, step. So we're looking here, aren't we? So we're concerned that there might be a fracture of her odontoid peg. Well, actually, you can see there's a fracture of her odontoid peg. Now, the key thing is, She's elderly with neck pain and not able to move her neck. She should never have had a plain X-ray. It should have been straight to CT. But we've done the X-ray, so we need to make sure that the X-rays are adequate. So I've shown you a lateral X-ray, but you also need to make sure that you've got an AP X-ray and also a PEG view. These are all three normals. So it's not three views of that one that I showed earlier. But if you hadn't X-rayed her neck and tried to mobilize her, what might have happened? Badness, basically, yeah. So always think, elderly falls with neck pain, image. And ideally, that imaging should be CT. If we think they've broken it, there's very little benefit of a plain film. So, number 4, young chap. He's a bit tall, slim, does lots of running, diving, mountaineering, rock climbing, you name it, he does it. And he woke up this morning and he suddenly got very sharp left-sided chest pain and he can't breathe. What sort of things should we be thinking of? I can't hear it, so I'll have to... Pneumothorax. Yep, so it could be a pneumothorax. What else could it be? Could it be a pulmonary embolism? Yeah. Could it be infection? Yeah. So you get the X-ray and you need to look. And what is it you're looking for? Looking mainly at the lungs, aren't we? But for any X-ray, you need to have a system. And for a chest X-ray, this is emergency medicine, so we don't know many letters beyond C, so we use an ABC system. Airway, trachea, is it central? Has it got something stuck in it? B, breathy things, aka lungs. So if we look at the right side, looks all normal, no obvious fluid, no obvious consolidation, lung markings all the way out. Yes, the apex does not show well. How about on the left side? What's this here? What are we missing? I've heard some murmurings. Yeah, we haven't got any lung markings there. And hopefully, come on, show me the arrow. So you can see there, yeah? Everyone see where that arrow is pointing to. It doesn't project well, I'll admit that, but you can see on the screen better that you can, so always look for where those lung markings are going out. And in the apex, especially, it can be very difficult to see the lung markings going all the way out. So, staying with the youngsters. Young chap, 32. He's with his missus, somebody else's missus, doesn't matter. He might not tell you some of these details if it's someone else's missus, especially if his missus is with it. Sudden onset of severe occipital headache post-intercourse. Worst headache he's ever had. Feels like he's been whacked around the back of the head with a baseball bat. Vomiting. He's shielding his eyes from the light, and this headache's not going away. Otherwise fit and well. He's a young guy, so blood pressure and heart rate probably a little bit on the high side, but nothing worrying. What's the worrying thing that we should be thinking about? Subarachnoid hemorrhage. So we can see there that on the CT, the white stuff is blood, and you don't normally have a nice arrow pointing at the blood on the CT scan. But given that history, and that if that CT was normal, would we be worried still? So normal CT does not rule out a subarachnoid. It's very good relatively early, but it loses its sensitivity quite quickly. So if they present 24 hours later, which is in its own makes it less likely to be a subarachnoid, but it may be they just could not get here for that time. The CT is already losing sensitivity, so you may need to consider, if the CT is normal, referring for a lumbar puncture.
Can I just point out that that scan looks like a CT with contrast, but it's not. That's just blood all the way through the subarachnoid spaces, right? Sometimes, when we request CTs, on the whole, we request plain CTs. So you might look at me, oh, they did a contrast CT. If you did, that's blood. But say some of us have discussed over the weekend patients that come in delayed, and you're like, well, as Paul pointed out, they're great early on, but are you going to see them? So sometimes you need to request a contrast CT. And this is about where we discuss with ourselves, but with our radiologists. They're part of our team, aren't they? We should be saying, oh, what do you think? It's 5 days. Are we going to see anything on CT? Do we need CT with contrast? Is it going to be something else on fancy scan? So it's very hard to just, because we own this patient at the moment, don't we? So we need to make sure we've got the right imaging. But that's can anyone see what's probably at that point there, that arrow? Have a guess. I'll buy a coffee for anyone guesses, right? An aneurysm, yeah, it looks aneurysmal, doesn't it? So it's probably an aneurysm. Great. Coffee for Karen.
Okay. So we now go back into our elderly population. Dave has been working in the garden. He's got some back pain. No neurology, no trauma, but lower back pain. And bizarrely, someone's actually x-rayed his back. What would we be thinking of? Aneurysms, yeah. I could lip read. So it could be that he comes in with back pain. It could be comes in, renal colic is a classic. 80-year-olds do not have renal colic until they've had their CT scan. Because if you look, you've got soft tissue mass on that AP, calcification. And if you then look on the lateral, again, you can see that he's nicely calcified aorta. Admittedly, this one's not that big, but if I have seen, I think I was an SHO neuro registrar sat, a chap come in with a 10-centimeter aneurysm. And when the ambulance turned up to take him to transfer to vascular, it's sort of, who's the acute transfer? That guy reading the paper. So if you don't think about it, you'll do the wrong imaging, just get a plain x-ray. In the old days, we did IVUs for renal colics, and you won't necessarily see that aneurysm. And we can see here that we can do a point of care ultrasound looking at the aorta. And what you end up with is the true aorta with clot and a false lumen where the actual blood's flowing through. That is approximately 7 centimeters, 6-7 centimeters.
Did you see the x-ray? Did you see on the x-ray where the aorta was? Did you see that? Did you see the calcification of the aorta there? So that was just incidental. I mean, we shouldn't do an x-ray for an aorta, but that's
So, other end of the age scale, one of my pet bugbears, monkey bars. 4-year-old has fallen off said monkey bars. It's come in, swollen, painful elbow. They are not moving that arm. Now, thankfully, our radiographers have kindly put something called red dot on there, which means they've spotted something. Now, it doesn't mean that there's something necessarily definitely wrong. It means they've spotted something unusual. And depending on who the radiographer is, it might be a reporting radiographer, or it might be someone who's just finished doing the red dot course. So it could just be a normal variant. So what are we thinking of? Young, 4 or 5-year-old, fallen, elbow pain.
Dislocation of the
So unlikely to be a dislocation of the elbow in a kid, but they can dislocate. Fracture is more likely. And when they dislocate, it's normally got an associated fracture. And the fracture we're thinking about in this age group is a supracondylar fracture. So if we look at the X-ray, you can see there's a lucency going through the distal humerus. If you look on the lateral, you can't actually see a fracture really. But what you can do is see something called an anterior fat pad. So see the lucency here? And you can see a posterior fat pad as well. So again, a lucency, and that's due to blood within the joint pushing out the fat pads that are normally adherent to that distal humerus. And if you then draw a line down the anterior humerus, the anterior humeral line, which should go nicely through the condyle, you see it misses it. So this is suspicious for a supracondylar fracture. If we look on the next one, it'll demonstrate the 3 lines that you'll be looking for. So you've got this anterior humeral line, the radiohumeral line, both in the AP and the lateral. And here, for all intents and purposes, a normal X-ray. But there's an anterior fat pad, there's a posterior fat pad, which means there's a fracture somewhere in there. And this is an older person, so I'm pretty sure that if you were to arrange, say, CT or MRI scan of that joint, you'll see a fracture involving that radial head. Yeah? In a kid, it's normally a supracondylar that they'd do. So, going back into the middle. 38-year-old chap, long history of back pain. Puts it down to a motorcycle crash years ago. It's getting worse, it's going to his left leg. And he's now got some difficulty passing urine, but has opened his bowels today.
Walk into the edge, please.
And he's complaining of intermittent weakness and numbness, but only of that left leg, the one the pain's going to. He's refused digital rectal examination. So with back pain, what is the thing we're not wanting to miss? Cauda equina. In that history, has he got any symptoms of cauda equina? You need to talk up, I can't hear you.
Not passing urine.
Not passing urine. So effectively painless retention can be due to cauda equina. That might be the only thing you've got. It may be urinary frequency, urinary dribbling. So if you think about somebody age 60 or 70, they may put that down to their prostate, not the fact that they've got an impingement on the cauda equina nerves. And rectal examination is compulsory unless it is refused. And we can see on the MRI scan, there's no value of plain X-ray, it's MRI or nothing. that we've got a disc pressing on the spinal cord here. And let's be honest, the sciatic nerve is the size of your index finger. Soft tissue pressing on it ain't going to do any harm. Nerves to the pelvis are tiny. You're talking millimetre or smaller. You put pressure on that, they demyelinate very easily, that nerve's dead. It may never recover. So, another youngish chap has come off his motorcycle.
Should we just mention about orthos and cord requirement? Because we've had a few over the weekend where people have said, oh, who look up, who looks after this? So just from a process point of view, you know, our job is the clinical assessment of these patients, and if you think it's cord requirement, and Paul's just highlighted, you know, you need good examination, good history taking, good examination, need a scan, don't have MRI. So a patient, us in the ED, either that's not our role. So just from a process point of view, you just need to remember that needs to go to orthopedics.
So in hours, do we almost have
No, we still refer
We
to
still refer to they
orthopedics.
have the ability because there are some slots kept aside for them.
We've been trying to get access to the MRI scanner during hours, but the reality is our MRI capacity is woefully inadequate at this hospital, mainly because the radiographers that can run the thing do not exist. So, going back, the youngish guy, come off his motorcycle. We're receiving centre for Brands Hatch. He's been on the track day. Helmet, scratched up, neck pain, chest pain, hip pain, and he's got some pain in his left wrist. So he's had his pan scan, which is normal. Are we worried? Aaron's definitely worried. So what are we going to get done?
that whole series of X-rays?
Yeah, so we'll get an X-ray. We'll get an X-ray of the thing that hurts, aren't we? So he's had an X-ray of the wrist, and you've got your AP view here and your lateral view here. Anything that leaks out at you. So go here. There seems to be overlap, doesn't there, with the carpal bones? They should be nice and smooth and in 2 rows. And there's not 2 rows there, and that looks suspiciously like a fracture. If you then look on the lateral, your thumb's not supposed to be articulating with your wrist. So he's got fracture with scaphoid and a perileonate dislocation. So as you can see here, carpal bone should be in 2 nice rows. You should have radius, lunate, hamate. That's an apple cup saucer or cup saucer table. There are 2 different things, but they should all be in a nice line, one sitting in the other. But this is one of those classic things that gets missed in major traumas because everyone's worried about the leg that's pointing the wrong way, the hole in the chest. 3 weeks later, they wake up in King's and their dominant hand is destroyed, and this is a manual worker. They ain't thanking anyone. So, a little while ago, 30-year-old lady has come to the emergency department with non-productive cough, low-grade temperature, and has just come back from the United States. Yes, this was before February 2020. She's not short of breath, has no chest pain, fit and well, not on any medication, including the pill. And you can see borderline tachycardia, but other odds are normal. So now we've said it's not coronavirus because it's before coronavirus happened. Or maybe it is coronavirus. Maybe she was an import. What other things should we be thinking of? Pulmonary embolism, yeah. So, there are two ways of assessing for PE. Initially, you can use something called the PERC score, which is the PE rule-out clause. And this is if we think somebody's low risk, can we reduce that risk to under 2%? The reason we use 2% as a cutoff is that over 2% is more than the risk of the investigation and the treatment. Under 2% is the risk of getting severe bleeding due to the anticoagulation, a reaction to the contrast, etc. And thinking of this lady, so she was, what, 30, 32? So she is under 50, yeah? Heart rate was 102. So we can't use PE rule out with her. And other things to consider would be oxygen saturations, previous history, recent trauma, surgery, on hormonal treatment, and the main one for those is the pill, which often doesn't get mentioned because it's sort of on any medication. No, so thinking I'm just on an inhaler or something like that. You need to explicitly ask, are you on the pill? Do you have a estrogen-emitting coil in place? Any signs of a DVT, any hemoptysis, if none of those are present, we could potentially use the PE rule-out to say your risk is less than the risk of us investigating and treating. And the other way is to use the bane of the emergency department, the D-dimer. And you need to think when to use it. It's very useful as a sensitive test to rule things out. But it's only sensitive in low-risk patients. You need to do a well score before, and the well score for PE at that. It's of no value when positive. So, going back onto a wrist. Relatively young, 50, has fallen onto the hand. Actually more punched the floor than onto the palm. And they've got wrist pain. And they've been sent round, they've got a Colles fracture, ED to pull. So, you see a fracture on the X-ray. So, is it a Colles fracture? So, the key thing is which way is the hand and radius gone. So, if you think about a Colles fracture, that's normally in the shape of a dinner fork. So your hand has actually moved back more dorsally compared to the forearm. You can see here, where's my mouse point gone? This has moved in the palmar direction. You can also see that this is massively off-ended, so something has gone seriously wrong with this ulnar ligament as well. We can see there that this is a Smith's fracture, and these are inherently unstable and are heading towards needing fixation. 50, generally it's worth if it's a relatively low mechanism, us trying to get into a better position if it was a Colles. But on Smith's, it's going to fall apart in the cast. It needs metal basically.
It's very easy with that one, you know, on a busy shift that someone, you know, they normally come from urgent care, don't they? And it's no one's fault. They just said I was deformed. You just assume because we see so many colleagues and they look swollen, but it's an honest, it's a Smith. So all of us would have been caught out at some point going and just got like, oh God, that's not a colleagues. But we do want you to get involved with manipulating joints, but Smith's fractures, that's a senior decision whether it's done just as Paul said. So do think carefully. We sometimes get this pattern recognition that we go, oh, it's another chest pain, it's another colleague. Really important just to challenge ourselves and say, is it definitely that? So it was all in the history. Paul said it was the way that they landed, it was probably different. And, yeah, so do have a look.
So, back into the elderly. So, a 90-year-old has fallen out of bed. They're demented. They can't give you a history. They're complaining of some pain in the right hip. And they don't really mobilise normally, but they can't mobilise at all now. And if you look at them, yeah, their foot's out a little bit. So what are we worried about? Fracture of a hip. So when we say fracture of the hip, obviously we're thinking neck of femur fractures. But don't forget you can have a fracture of the pubic ramus, the neck of femur, the proximal femur not in the neck, but also the acetabulum itself. And if you look on this right hip, I'd argue you can't see a fracture line there. What you can see though is that Shenton's line, whereas the left one is nice and smooth, is sharp, which is highly suspicious of a fracture. Yes, I'm aware this is now the opposite side. So you would then go on to ideally an MRI scan, but when we spoke about cauda equina and the issues of having an MRI capacity, so we might need to accept getting a CT as a better option in the short term. Because what you don't want in these elderly patients is them to be lying in bed for 4, 5, 6 days waiting for an MRI scan. If they can mobilise, they need to be up. And that's the whole reason we want to operate within 24 hours on these. Because every day they're in bed is days longer they're in hospital. And the chance of them ever getting home or even walking again is plummeting. But you can see that there's a definite kink there, and that the bone is just compressed in on itself.
I think we see more neck of femurs here than in most places, certainly in the south. So I think this is all like 400 plus neck of femurs last year, which is all more than once a day. So it's really commonplace, and we need to think about it. Maybe I think I'd add to Paul's X-ray description is, remember sometimes we see, especially elderly patients, mobilise on neck of femurs. In fact, someone told me here that their grandma mobilised on it for a week.
I've seen someone pass OT and physio and come back 3 weeks later.
I'm sending you bits as we go along. So
With
forgive the spam, but you have to look at, if you remember from med school, that Garden classification, there's 4 different classifications. And Paul was a surgeon, so he's much cleverer than me, but there's a set, I can't remember if it's 1 or 2.
So Garden 1 is basically doesn't move, Garden 2 is squeezed, and those 2 can both be managed by just putting a piece of metal in and holding that head in place. Garden 3 and 4 are where the ball of the femur has come off the head, has come off the spike of the neck basically, and those you need a form of hip replacement.
I think the 1s and 2s, they don't move. Sometimes they're still in place that they can articulate and they actually are still able to mobilise them. So remember, have a very low threshold. I've said to some of you, don't just injure people for the sake of it, but with the elderly, we should have a lower threshold than thinking, hold on a minute, you've had a fall. Just the fact that they've got up doesn't sort of negate a neck of femur. So we probably month. You know, Mr. Pervez will send out the clinical governance newsletter, and we sadly miss them that regularly. So it's really important we think about it. And I think in this age group, if you've got suspicion, having a pelvis X-ray is not the worst thing in the world to have a look for those fractures, because we certainly pick them up, don't we, on a regular basis. And use about fibs.
So obviously, if we do have a broken hip and they're in pain, and there is no contraindication, and the main contraindication is patient refusal, then what we would normally look to do is give them a fascia iliaca compartment block, which is a regional local anaesthetic technique. Primarily blocks the femoral nerve, also the lateral cutaneous nerve of the thigh, and theoretically the obturator nerve as well. And it works in about 70% of people, to the point that they only need paracetamol for pain for 16 hours. The anaesthetist will claim, oh, we can get 99%. Yeah, that's because you're doing this for hip replacements every single day of your life. We are doing one a month, one every 2 months. So even using ultrasound, we're not going to get anywhere near those numbers.
But it makes a big difference.
But
the morphine requirement for these patients goes down.
The morphine requirement goes down. They can sit up. You will see if it works well, some of them will actually sit there bolt upright with their hip bent up even further, because they cannot feel the fracture pain anymore. But don't forget that not all fractures in the elderly are of the neck of femur. So this is a left side, and you can see we've got a fracture line here. So that could be a higher pubic ramus. It could also be involving the acetabulum. And the only real way to tell for certain is basically to get a CT to establish where is that fracture going. Because once you know, you can then determine, can this person put weight through that joint. Next one, relatively young, known to have a history of reflux, heartburn, coming severe epigastric pain. You got a chest X-ray because everyone gets a chest X-ray.
You're looking for perforation, maybe, and looking for the air under the gastric.
Absolutely. So you can see that is the liver, and that is the diaphragm. So I said that chest X-rays, in emergency medicine, we're simple folks who just like letters of the alphabet, generally not much beyond C. This one at least we got to D for diaphragm. So you'd be highly suspicious for a perforation. Something, twisting injury, severe knee pain. Can't mobilise. So on the Ottawa knee score, they get an X-ray. Okay, so your patella's here. It looks normal. And here looks normal. What do we think of the tibia? Yeah, so that is probably the fracture line there, but it may almost be invisible on the AP. All you may see is some widening of that tibial plateau. Here you can actually see the depression, but you can see almost normal X-rays, something like this, with absolutely horrific CTs. And this needs fixation. It basically needs a knee replacement in about 5 years' time, because that is not going to do well. But if someone's only 40, you don't need a knee replacement now. You need it as late as you can get away with. What's going on? Yeah, so we've discussed it, and look at all cortexes. So make sure you look everywhere for any breaking that cortex to suggest a fracture. So, 70-year-old guy, 70-year-olds are want to do around here. They're deciding to, well, this one was putting up a birdhouse. They adjust satellite dishes, put up TV aerials, change curtains over the top of the 3 flights of stairs. And he's landed on his right side, but walks around. He's 70, he's a stoic chap. He still works, he still drives a truck. He doesn't drive the trucks, he's got people that does that for him. He owns the business. Everything's normal. He's actually had a fast scan, which was completely normal as well. But the nurse comes and grabs you because it's a little bit sore, so they're just helping him get dressed. And they notice this all down his right side. So, what are we thinking? Yeah, so it might be something intraperitoneal. It's more likely to be something retroperitoneal. So, that's the Gray Turner's sign, which often is associated with end-stage pancreatitis. But it can be due to a retroperitoneal bleed, such as an aneurysm, or bleeds that have gone retroperitoneally. 15-month-old boy, come into the ED, fell over a couple of days ago, he's a toddler, falls over all the time. And his x-ray shows an undisplaced tibial fracture. And just as you get in, the nurse is getting everything ready to put the plaster on, one of the other nurses comes in and says, "Hang on, isn't that Tommy? I put a sling on him 3 weeks ago." Otherwise fit and well. NAI, non-accidental injury. So, make sure you look at the safeguarding list. This is one of the old ones. It's now printed in black on the CAS card as opposed to blue. Don't forget paediatric safeguarding in adult presentations. We are notoriously bad, not just as a department, nationwide, of remembering the kids with the drunken adult. An adult can get drunk. It's a free country. Alcohol's legal in this country. But the key thing is, when they got drunk, where were the kids? So it's always something to consider for any potential safeguarding presentation, both with a pediatric one and with an adult, of where are the kids? Is this a safeguarding presentation? 99% of the time it won't be. But that 1% could be catastrophic.
We're seeing a lot of mental health at the moment, aren't we, in the department? You've already seen lots of it, so we must ask those patients as well. Do you have children? Where are they? Who's looking after them? It's not about being judgmental. It's just, if they're suffering, we also need to make sure that their children are being looked after. And more often than not, if you phrase it correctly, it's not an accusatory way. It's more about support. So it's absolutely, you can't justify not asking that and documenting that. You'll have seen already the nurses are very good at doing the safeguarding referrals, both for domestic violence, adult safeguarding, but please, it's also a doctor's role as well to make sure it's all, we tie all those pieces together.
Because all it takes is for every single person to forget, and that opportunity's been missed.
We have a Friday meeting, where Paul's the PTD lead and I'm a PTD consultant.
Who doesn't work on Fridays?
Why would you? So in that meeting, all the children get reviewed. So there is a safety net there, which is great. Of course we want that, but it's not great for us if we have to phone up 4 days later to chase detail. The best history is taking first time round, isn't it? So you're the ones that have got a relationship with that patient. You have to make sure that holistic stuff is done as well. It will be flagged up, and don't worry if we come to you on a Friday, Paul probably, or the PE sisters come to you and say this wasn't done. our notes have to be up to scratch. One thing that I'm guilty of is that we take very good histories, we don't necessarily document everything that we've done. So please remember, it's about focused histories, but the safeguarding side of it is
those under one injuries must have a senior review, and that senior review must be documented. It often happens, often doesn't get documented as well. So you need to make sure it is clearly documented. If one of us sees and says, actually, we're happy with the story. If then we miss the fracture, we've missed the fracture, and 3 days later it shows, so, well, it's not a delayed fracture, we saw them at the time. We didn't feel there was an injury then at that point. They still weren't walking, so we x-rayed a couple of days later. Oh, there's a missed fracture. But it's all about making sure everything is documented and think about safeguarding. 74-year-old, early onset dementia, a couple of days more confused, has recurrent UTIs, indwelling catheter at the moment, waiting his prostate. And he tends to fall over a little bit, and he's got catheter in, but he's got a urine dip, and his white count's 11, neutrophils are 8, his urine dip's 3 plus a leukocyte. So everyone happy to send him home with some nitrofurantoin, yeah? Who isn't happy to send him home with nitrofurantoin? And not just because this is the things not to miss. Well, funnily enough, he had a bruise on his head, so he had a CT. You can see sort of subdural, and you've got some whiter stuff in with the darker stuff there, so that's an acute on chronic subdural. Be very aware that urine dipsticks in the elderly are notoriously poor in sensitivity and specificity. Don't grab hold of them to say, oh, this is a definite UTI. A UTI causing confusion is a delirium, so they're generally going to have something systemic going on. So always think, am I missing something? Eight-year-old falling off his monkey bars again. Can we just burn all monkey bars from trampolines? Onto his arm, and coming a couple of days later, he's still not using his right arm. It's Monday morning. He fell off on Saturday, and parents just thought I didn't want to go to school. But yeah. So it's actually a little buckle fracture,
Dr. can you contact
where the bone has just literally just buckled. So there's no real break in the cortex there. Now these can usually be managed very well, and if we had the right size splints, don't even need a plaster. So it's very much dependent on the size of the child to see if we've got a splint small enough for them. 89-year-old chap, tummy pain, not eating, the classic nursing home description, coffee ground vomit. I'm yet to see a coffee ground vomit that actually have an upper GI bleed. Not opened his bowels for about 4 days now, passing urine okay. We worried? Firstly, 80, 90-year-olds with abdo pain are always a worry, because they may not show you typical peritonitic signs. Oh. So, get that senior review. Wasn't an aneurysm this time, it was an obstruction. We can see lots and lots of dilated small bowel loops. And the rectum and sigmoids effectively cut off, but you could virtually nothing visible in the colon at all. And finally, Twisted ankle. Medial pain. Also painful lateral knee.
People that fracture.
So, be aware of the medial ankle sprain. There is no fracture on that X-ray of the ankle. But there's a little bit of opening up of that tibial side. And if you look and felt, so always document that you felt that fibula. I know we don't see many minor injuries, but always think, if it's a medial ankle sprain, is there something going on higher up? Think about the knee. And if you X-ray it, you see that higher fracture. So that fracture has gone all the way through here, taken out the deltoid ligament, split the fibula-tibial ligament, and taken out your proximal fibula.
Well, we don't, musculoskeletal stuff goes next door, really, but we see so many fallers, elderly fallers, so that, I think so many of your notes are really high quality, but when your systems review, don't forget musculoskeletal as a systems review as well. But generally, I know you do cardiovascular, respiratory, outdoor, neuro, we learn at med school, but musculoskeletal must be on it as well. It might just be NAD, but it shows that you thought about it. And this isn't about litigation, this is about us looking after our patients, isn't it? So, I know I'm guilty of not writing it down, and just as Paul said, with the joint, whenever you see a joint, think about the joint above and the joint below, not just for examination, but for imaging as well. And that's a ring structure, isn't it? It's very hard to, you'll break a polar, you can't break a polar mid in one place. So if there's something that looks mischievous there, you have to check the top end of the ring. And again, sadly, we missed it. All of these are like, it's like therapy for me and Paul. We watch these are like things we've seen over our career that we keep. In fact, these are all my X-ray studies. So I'm having like flashbacks, but literally all of these are ours. But so, you haven't examined up here because they're pointing their ankle, just focused on that. The radiographers often help us out, don't they? I know we sometimes would meet about them, but they say, ankle, but they do an extended.
Do you want the knee?
Yeah.
Basically dropping a subtle hit.
Someone said to me over the weekend, it's a neck femur, but they got, should we do the femur as well? Because, could it be a periprosthetic fracture down there? And the radiographers already done it. So, do just think more laterally when we do this, because it's,
So, we've gone through 20. There are lots more easily missed things, but the key thing is think about what it is that you cannot miss on this presentation. We are used to the more medical things of, it's chest pain, we mustn't miss an MI. It's shortness of breath with pleuritic chest pain, we mustn't miss a PE. But remember the more subtle things, the elderly back pains, the elderly abdominal pains, the joints, are things to look out for. Because if you don't think, is this an aneurysm, you're not going to do the ultrasound and you'll never pick it up. You don't think, this young guy that's got a bit of a cough doesn't need a chest x-ray. The vast majority won't even get past UCC. You can't x-ray, they don't have chest x-ray rights. If you don't think, is this a pneumothorax, you won't get a pneumothorax x-ray. So, remember to interpret those x-rays with the clinical picture. Use a systematic approach to identify so you don't miss something. I know I'm mockingly say A, B, C because we can't think of any further, but that way, if you're going through each thing, that will get you the best chance of not missing something. Pattern recognition comes with time, but even then, if the pattern doesn't fit, you may have to go back to first principles of, have I missed something? Especially at 3, 4, 5 in the morning. And if you're not sure, ask. Thank you. And bye-bye.